as people want and answer any questions that you have. So what I'd like to probably do, and again, this is possibly going to change, is have the exam here. It means we'll go over the exam, review exam, and do lymphatics. And then that gives us these days here for the immune system. Okay? Immune's a big chapter. So one of the reasons why I want to make sure that this day stays free. Okay? If we progress pretty quickly and I get through more than what I anticipated, then the exam will be here and the lab will be there. Because the lab's going to consist again of dissecting the heart and doing an EKG. Okay? And the EKG is exciting and it's fun, that type of thing. The more important thing is the heart dissection. So again, you kind of get an idea about the structure and so forth. All right. So we have two types of cells in the heart. Remember, we have pacemaker cells and we have contractile cells. Okay? Most of them are contractile cells. They're the ones that actually are the skeletal, or not skeletal, the cardiac muscle fibers that will shorten and they cause the blood to move in a forward direction. Okay? The pacemaker cells are the ones that essentially tell those cells when to contract. So as we go through this process, you remember that I talked about this all or none phenomenon. Okay? So in skeletal muscle, I choose how much muscle I'm going to contract based off of the load that I'm trying to move. So again, as I walk across the room, I'm going to be using a lot or a much smaller amount of skeletal muscle than if I go into a full squat. Okay? Now, cardiac has this automaticity or autorhythmicity. So again, I can remove that cell or that heart and it will continue to beat on its own. Now it is innervated, and I'm going to show you the innervations today, so I can modify that. I can speed them up and slow them down. But the heart will still beat all by itself, primarily because of those pacemaker cells. Now we talked about this refractory period. So again, when you look at it, this is from a different textbook. This is skeletal muscle refractory. So it's much, much shorter action potential because it's going to allow for me to let the muscle relax and start again. I can't have that up here. See, I can have a cramp in my thigh. My rectus femoris can definitely cramp up. If it cramps up in my heart, then I die because the heart's not going to be able to continue beating in a fashion. Now, one of the ways that this works is because we have these branched processes. So remember some of the differences that I talked about in between skeletal muscle and cardiac muscle. Skeletal muscle goes the whole entire length of the muscle. So again, the longest muscle in your body is the sartorius. It starts up here on the iliac crest and it's going to go all the way down here to the medial thigh. That whole muscle is filled with skeletal muscle fibers, and the muscle fibers travel that whole entire distance. These are short and they're branched. Okay? So they allow for communication, and they have these things called gap junctions that exist so that you can have this game of telephone. Again, if I was going to be the pacemaker cell and I started over here and I said we're going to contract, then each of these individuals are going to start telling everybody it's time to contract. Okay, we do that with chemicals, with electrolytes in the heart. Here you just be using your voices. Now, the overall setup inside is the same. We still have our T-tubules, we still have our sarcoplasmic reticulum. There's a slight difference as far as the number goes, but that's not one of the more important parts. One of the other important parts is the fact that this muscle doesn't stop. Okay? So when we lay down at night, again, our legs stop moving, but here, the heart doesn't stop. So the amount of mitochondria, which produces our ATP, has to be significantly higher. Okay? About 2% in skeletal muscle, about 25% in cardiac muscle. Again, number's not super important, but you should know a lot of mitochondria. Now, when we look at our action potentials, again, you guys are used to seeing action potentials that basically go up and go down, where we have our depolarization and we have our repolarization. Okay? here, if you notice, there's a slight difference in the action potential. We have this plateau that occurs. So what you see here is what's occurring in the contractile cells, not in the pacemaker cells. I'm going to show you that one in just a second. So I ran over this fairly quickly on Thursday, just so, because then I said I'd, review it on Monday. So here in the blue is my action potential. It goes up, and again, it's being caused by sodium coming into the cell. So that part's not any different than any other cell that is able to be depolarized. Sodium is generally the primary ion that causes that. Now, as it gets to the top, right about here, we have two things that are going to happen. Our potassium gates, some of them are going to open, but so do a slow calcium channel, slow calcium gates. Okay? Now, calcium is on the outside of the cell. So when calcium starts to come in, it causes this, instead of an immediate repolarization like you see here, it causes a plateau. So it's not a complete plateau, but you notice that we're not immediately going back down to baseline. It's being retarded slightly for two reasons. First, the calcium is a slow calcium channel, so it responds slowly. Okay? It's not how fast something comes in, it's just how fast they open. Second is, there are some potassium gates that are open. And again, if the potassium gate's open, potassium is generally where inside? Potassium is where regarding the cell? It's on the inside of the cell. Gave the answer away. So when it opens, potassium's going to want to leave. And that's going to cause the slight decrease that you see here. And then eventually the calcium channel is closed, and we have potassium channels open, and we have repolarization. So again, as I stated on Thursday, sodium, calcium, potassium. And to make it easier for you, I write sodium in, calcium in, potassium out. It's another way of getting into your brain what direction things move when you open these doors, when you open these gates. Now you can see it takes a little while to generate tension, which is what you see here, before the heart starts to contract. And then again, you see that very, very long absolute refractory period to prevent the heart from seizing up, cramping, so to speak. Now, this is what happens in the pacemaker cells. Now, the pacemaker cells, far fewer. Again, about 1% of all the cells. 99% are the contractile cells. And we have what's referred to as an unstable baseline. Okay, they actually use a term called a funny channel. That's its actual designation. So here, what happens is the potassium gates completely close. Okay? At this particular point. Sodium, we have leaky sodium channels. So they're not fully open, but they allow sodium to slowly start coming in. When enough sodium comes in and we reach threshold, then all the sodium channels open. Except here they're not sodium channels, they're calcium channels. And the difference between this one, this is a slow calcium channel. This is a fast calcium channel. These are all voltage gated, so once the membrane reaches a particular voltage, it'll shut off. The potassium gates then open up. We have repolarization, and again, they're voltage gated, so they shut. Now once they shut, then the sodium leaks in again and causes another. So every time this happens right here, it's basically causing this in all the other cells. So every time this happens, that's going to cause a pulse. That'll cause a contraction. Okay? Now it's obviously not going to be minutes to minutes, and you don't have to get into the millisecond component of it, because what you're seeing here is the electrical component. I'm going to talk about that when we get into the EKG. But as you stop and look at it, that will cause the contraction, so milliseconds later is when you'd be able to feel a pulse. Okay? But unless there's something wrong with the electrical system, and for right now we're talking about a healthy heart, this is what causes the heart to beat. Okay? And again, as you did with the other one, I would write leaky sodium channels, potassium channels closed. Fast calcium channels, calcium comes in, and there we have our potassium channels open. Now, does anybody remember from last week what the significance of the calcium here in our contractile cells coming in does? Yes, ma'am.
It triggers more intracellular calcium release.
Right. So normally, it's a depolarization that causes the sarcoplasmic reticulum to release calcium. Okay, and that still happens to a certain degree, but most of the calcium, well, not most of it, the trigger for calcium to be released comes from the calcium entering here. It's about 10 to 15, some books even go as high as 20% of the calcium that's needed for contraction comes from extracellular, and the rest of it comes from intracellular. That's what's referred to as calcium-induced calcium release. So it's the calcium coming in from the extracellular fluid that causes the calcium to be released intracellular. Now, these pacemaker cells are positioned in the heart in very specific places. Okay? They're referred to as nodes. Okay? Now, the numbers I'm going to give you are going to vary from textbook to textbook. The important part is the trend. Okay? So, the first one is called the sinoatrial node. And a lot of you, if you've had any type of cardiac stuff before, probably have heard it as the SA node. And the SA node is up here. It's actually the general. It runs the show. It will send an impulse. It will depolarize. So when I say it's doing this, this is what the sinoatrial node looks like as far as its action potential goes. So once it depolarizes, it's going to cause the impulse to go throughout all of the atria, both the right and the left. So these little dots are that telephone game I was telling you about. It's time to contract. Okay? And that impulse is going on. Now, for the most part, the SA node is going to be about 70 beats per minute. Now that can change. It can change based off of your endurance training. It can change based off of drugs you're on. It can change based off of temperature. It can change based off of oxygen levels. A variety of things can change. But this is kind of the average, 70 beats a minute. Now, besides sending impulses out to the rest of the atria, it's going to send impulses to an area called the AV node, the atrioventricular node, which is in the bottom part of the right atrium. Atrioventricular node. And that's going to depolarize about 60 times a minute. Now, the only reason that that would depolarize 60 times a minute is if it didn't get the phone call from the SA node. So if the SA node is passing impulses along at 70 beats a minute, this is going to pass impulse along at 70 beats a minute. It will not fire on its own unless it does not get a phone call from the SA node, an impulse.
So every beat is every time it depolarizes?
Every depolarization would cause a beat. Now, remember I told you that there were gap junctions? The gap junctions was essentially how those impulses were being transmitted via electrolytes. They just kind of moved through there and caused a depolarization. The AV node has much smaller cells. They also have fewer gap junctions. Therefore, there is a delay here. Okay? And I'm going to tell you the importance of the delay when we get into cardiac, the actual contractile phase on the Wigger diagram. But here, there's going to be a delay. And just as a kind of a T, so to speak, it's to allow all the blood in the atria to be down in the ventricles before it passes the impulse along. Okay, that's the purpose of it. Now, for the most part, from an electrical standpoint, there is no connection for healthy people. Okay? There is no connection between the atria and the ventricles except the next one that I'm going to show you. Okay? It doesn't go down this way, and it doesn't go down this way, except in non-healthy people. Okay? That's why we have cardiologists, because we have people that have wiring in their heart that's a little screwed up, and we have to figure out where it is. So to be able to cause the ventricles to contract, there has to be this connection. And the connection is right here. It's the only connection between the ventricles and the atria in healthy people. Okay? And it's referred to as, it has a couple different names to it. It's either called the AV bundle, and the AV stands for atrioventricular, or the term that most of you are probably going to hear is called the bundle of His. There's only one S, there's not two, it's not like a snake, but it's not the bundle of His. It's the physiologist that discovered it. So bundle of His. And that's this structure right here. The only connection, again, between the atria and the ventricles, from an electrical standpoint. Now, these depolarize about 50 beats per minute. Again, if the heart's beating at 70 times a minute, it's going to conduct the impulse at 70 times a minute. The only time it's going to beat at 50 times a minute is if it doesn't get a phone call from up above. Now, these are then going to branch off, and they're going to form what's referred to as our bundle branches. So those of you who've worked pre-hospital, those of you who've taken care of a patient, you might have listened to history and someone has a bundle branch block. This is where they have a block in the bundle branches. There is a left bundle branch and a right bundle branch. And they're going to beat about 40 minutes. Now the left actually does have a second one. We're not going to get into it. There's a posterior and there's a septal division. But we're not going to get into the weeds that much. Yes, ma'am.
I have a question. I'm not sure if you're going to touch on it, but the delay from the 70 beats per minute between the SA and the AV node, is that going to change it? Like how much is it going to change it?
I mean, how long is the delay? Probably about 50 to 75 milliseconds.
Oh, okay. So it's not going to be like...
No. These are all, like I said, this is all milliseconds. I mean, when my heart starts, if I go running or if I swim or what have you, and my heart rate goes up to 140, there's still a delay. But it's a much shorter delay. It doesn't just, it's not like, dude, we're waiting, come on, you know, military, hurry up and wait. It's,
And it wouldn't change the 70 beats per minute?
no. Now, these are then going to move up into the actual wall of the ventricles. And they're called Purkinje fibers. And that's the last of the conduction system. And that's about 30 beats a minute. So what have you noticed as we start to move down the nodes, as far as the rates go? They go slower. That's the take-home message. Okay? I mean, you should have an idea the average is about 70 from an SA node, and then what you should get in your head is that as you start moving down, they go down farther. So again, nothing's going to happen as long as, so if you think of this as a battle, and I'm getting an order from the general's going to pass, and I'm going to skip some, so those of you who've been in the military, I'm not, the general's going to let the captain know, the captain's going to let the first lieutenant know, first lieutenant's going to let the sergeants know, and the sergeants are going to let the rest of them know. That make sense? So if the captain doesn't get a phone call from the general, the captain is now in charge. And the captain is the one that sets the pace.
So did you say the nodes were just different types of pacemaker cells?
Right.
So these paces apply to if no one before told them to have a different pace?
Exactly.
Even all the way down to Purkinje fibers?
Yep.
Okay.
Yep. Now, if something happens, so let's just say the bunker was taken out and the general's gone, then now the captain's running the show, and you will be beating roughly at about 60 beats. And that can happen for a variety of reasons. Again, it can happen because of drugs. It can happen because of a heart attack, not that common at that particular level. Usually they hit down here. Hypoxia, those types of things.
So, if the SA is taken out and then you're down to the captain, then is that regardless of what you're doing?
Mm-hmm.
Okay.
Yeah, there's going to be a limit to, if this is taken out, there's going to be a limit to what this can do. He doesn't get a promotion. He still has to do duties, but he doesn't get a promotion. So he's going to stay there. He might be able to speed up a little bit, not a lot.
I just want to make sure I heard correctly. The right and left bundle branches, when they become part of the ventricular wall, they are all
Right. They kind of divide, and then they start sending out like little tentacles. And little tentacles go to the Purkinje fibers. Okay? Now, I think I have it in here. Double check. So this is, again, from a different textbook. Instead of using the military analogy, they use the train. So if the engine, the SA node, is driving at 70 beats or 70 miles per hour, 70 beats per minute, hopefully you get that connection, then everything else is just going to get pulled along. Okay? If something happens in this engine, then the next one in line sets the pace of the train. Okay? Now, they kind of start zipping down as we move. Occasionally, you can get some pissy cells. So this is a pacemaker cell, and it doesn't want to wait. It gets irritated for some reason, whether it's hypoxia, whether you're getting some medication, and it starts firing. And because it starts firing, it pushes the train faster than what this one was going at. So in other words, this one sets the pace. Okay, this is a disease process. This isn't what happens when you go running. It happens when you go running, and what happens you get excited. This one increases in speed. This is, again, a disease process where this patient would need to be taken care of immediately. Now, this is the picture a little bit better drawn than mine, but SA, AV, bundle of His, right and left, bundle branches, Purkinje fiber. Now, I told you that the heart was innervated. Okay? So, up in the brainstem, we have what's referred to as the cardioacceleratory and the cardioinhibitory. Now, the parasympathetic nervous system, bless you, originates up there and is actually going to be part of the vagus nerve. Okay? And I'll talk about that in just a second. The cardioacceleratory is going to go through the sympathetic ganglion chain, which is right here. Now that's really not that big of a deal. I don't care that you know that it exists there. What I care that you know is that there is a cardio acceleratory and a cardio inhibitory center in the medulla. So the cardio inhibitory obviously is going to slow down, and it innervates the heart in two places, the SA node and the AV node. So again, if you are somebody who is fairly well trained from an endurance standpoint and you have a fairly low resting heart rate, it's because you have a very prominent parasympathetic tone. It's active. All of us have it. This is the reason why most of us, even though we're sitting here not doing anything, your heart rate's less than 100. If I was to just secretly go up and snip your vagus nerve, your heart rate would actually increase to about 100 automatically. So your parasympathetic nervous system is actually keeping your heart rate down when you're just doing normal things. Now, if you notice the sympathetic nervous system, not only does it innervate the SA node and it innervates the AV node, but it also innervates the rest of the heart. Now here, it's directly innervating the SA and the AV. This is, if you go back to our AMP1 when we talked about the viscosities of smooth muscle. So we had the nerve cell. So skeletal muscle is me handing you a letter. Okay? In smooth muscle, it's I'm doing a bulk drop in your neighborhood, and it's just being released out. That's somewhat similar to how this works. This is actually being delivered to the surface of the cells on the sympathetic nervous system at this point. So again, when you look at the diagram, do not get too lost in this idea, well, this is coming from the medulla, but the sympathetic is actually coming from this sympathetic chain right here. That's not that important. The important part is cardio-acceleratory, cardio-inhibitory. They affect the parasympathetic and the sympathetic. You should know where they innervate. So parasympathetic innervates just the SA and the AV, and the sympathetic affects AV, SA, and the rest of the heart itself. So again, for those of you who have either been working pre-hospital, those of you who worked in the hospital, one of the things that we occasionally will do if somebody has a very, very rapid heart rate, something like this. Okay, so this is not, again, this is not somebody who's just, this shows up differently on an EKG. So I know it's them just not being excited. Okay? And in that instance, we might want to slow them down, and so we do what's called a vagal maneuver. The term vagal comes from the fact that I'm going to activate the vagus nerve. The vagus nerve is a parasympathetic nerve, and it slows the heart rate down, whereas sympathetic speeds the heart rate up. Now, if I brought in Lance Armstrong, sat him down, took his pulse, and his heart rate was 41, where is that impulse coming from? Pardon me?
SA.
I have an SA. Anybody else? Because we have 40s over here at the bundle branches. Why wouldn't it be coming from the bundle branch?
His heart's so strong that it doesn't need to beat that hard.
Partially correct. I mean, you're correct, by the way. The whole thing is correct. But what you just said was only partially correct. So you actually wouldn't really be able to tell. If I walk up to somebody, regardless of who it is, and I feel their pulse and their heart rate is 40, I wouldn't be able to tell you where that's originating from until I do an EKG, until I put you on a heart monitor, and I can actually visualize it. Now, more than likely, because that's what Lance Armstrong's heart rate usually is, we're not going to, question that. He's an endurance athlete. Most endurance athletes don't ever go below 40. Most of them spend their time around the high 40s and low 50s. But that's, a range you're going to think about. So I actually have to look at it now as far as his heart rate is low because he has increased parasympathetic tone. He's got a good heart, so his heart can beat more blood with it. So it's the opposite of what you were saying. They're connected, but it's not because his heart is more efficient that it beats slower. It's slower, and he can survive that way because his heart beats more efficient. Okay? It's like which came first, the chicken or the egg?
Is the 40 to 50 beats per minute, at rest?
Yes.
Okay. And that's for everybody, not just in the captain? Like, that's the range for every typical adult?
No, that's based off of your,
So that's just for endurance?
yeah, but this is the average you should
Okay,
know.
okay.
So if I was to actually come in here and either put you on a heart monitor or take your pulse, depending if you know how to do it so that you're not getting people all excited and, you know, I mean, every time I go to the physician, my blood pressure, even though I've worked in the healthcare for 30 years, my blood pressure is off the charts. I think I have an IT band problem. I went to urgent care yesterday afternoon to get a PT referral, and my blood pressure was like 150 over 93. And it always freaks them out. It's like, it's fine. When I leave and I take my blood pressure, it goes down. So it just depends on what's going on.
Okay.
That's the thing. So in this instance, again, I might have some people that are at 80. I might have some people that are at 40, 45. So again, I'm going to look at this EKG, and that's what we're going to start talking about, is the structure. So this is what would be considered a standard 1-beat EKG, okay? And again, as I stated before, EKG, the K stands for cardiac, but because it was invented by a German physician, K, we've always kept it. And by convention, as I said at the very beginning of the term, when we talk about basal ganglia, you're going to still see, you know, an ECG department. And when you see an ECG department at the hospital, they're going to call up and ask for a 12-lead EKG. It's just one of those things that will stay around for quite a while. When we look at them, there are 3 waves that you need to be familiar with, and then we have intervals and we have segments. Okay? This by no way, shape, or form is going to teach you how to be a phenomenal person for EKG. I will tell you, if you are ever planning on working in a field that does EKG, so even if you're going into nursing, if you're not going to be on a telemetry floor, if you're not going to be an emergency room nurse, an ICU nurse, there's really no reason to get in the nitty-gritty of EKGs because you don't look at them every day. That's all there is to it. If you're a paramedic, this is actually something that they will weed you out of. Usually the first term of most paramedic programs is cardiac, and they use it to weed people out. So I always tell people you should have your EKGs just down if you're going to the paramedic program. But there is a book called Rapid Interpretation of EKGs by Dubin. It's the cover of it is this orange color, like right here. But it's probably the best EKG book I've read. Tons of them. The reason it's so good is because he basically at the top has a paragraph of information. And then underneath that paragraph there's about anywhere from 3 to 6 questions that essentially is asking you the same thing over and over and over again. So by the time you move to the next page, you kind of have that down. It's one of these books that you truly could probably sit down in about 3 hours and go through, and not only does it teach you about just EKGs, but it teaches you about reading a 12-lead EKG. It's a phenomenal book. I don't get any kickbacks for it. It's just an excellent book. So the waves that you need to be familiar with are going to be the P wave. I'm going to combine actually 3 waves together to form one of the waves I want you to know, which is called the QRS complex. And then you need to know the last wave, which is the T wave. I'm going to go over each one of these. Okay? Just want to give you a couple definitions before we start. I told you that you needed to know what a segment was. A segment is essentially a flat line in between 2 waves. So a segment does not include a wave. And then we have an interval. And an interval is a segment that includes at least 1 wave. And again, I'm going to break all these down. We're going to go through it nice and slow. So our first wave we're going to talk about is called the P wave. Okay? Now before I talk about the P wave, I want to say something that I'm going to say over and over and over again. An EKG represents the electrical activity of the heart, not the mechanical activity of the heart. I hope that the electrical activity causes a mechanical activity. But that's not what's shown here on the EKG. The EKG is only the electrical components. Now, the P wave represents atrial depolarization. That's an electrical event, meaning that the atria, that picture that I erased that showed the SA node sending the impulses out to the atria, that's depolarization. Now, I guarantee you that you will find people, if you ask them, what does the P wave represent? They're going to tell you it represents atrial contraction. Do you think contraction is a mechanical or an electrical? Mechanical. So no, it does not represent atrial contraction. The P wave represents atrial depolarization. There are disease processes where I can have a P wave on a screen, but I do not have atrial contraction because there is a problem, a medical problem. What do I hope atrial depolarization causes? Atrial contraction. Now, the second wave, remember, was actually 3 waves all put together. The Q wave, which is sometimes referred to as the first negative deflection. In other words, it's the one that points down. And then we usually have a positive deflection, one that goes up. That's the R wave. And then we have the S wave down here, which is the second. Now, the reason why we show this particular picture is because we see a Q wave. When you start looking at patients' rhythms on their monitor, depending on the leader, depending on the patient, you don't always have a Q wave. This might not be present. It might go directly into an R wave. So that's why we show this, because this is a nice stereotypical EKG. This represents ventricular depolarization. That whole QRS. Why do you suppose there's a difference in size between the P wave and the QRS complex? Pardon me? They're larger. They're stronger. More muscle. Therefore, there's going to have a greater electrical impulse that's going to be able to be documented on an EKG. The T wave represents ventricular repolarization. In other words, this heart is now resetting itself so that it can beat again. Remember, we have that absolute refractory period that we have to take into consideration, but for the most part, we have our repolarization here. So if I have atrial depolarization, ventricular repolarization, do the atria not repolarize? They have to. Every muscle that gets stimulated has to repolarize, or else you will never be able to depolarize it again. So where is it on the monitor?
Ventricular depolarization.
It's probably buried somewhere in here. Now, even if you could find it, look at the size of ventricular depolarization and the size of ventricular repolarization. The repolarization is always much smaller. Well, look at how small the P wave is. So more than likely, its repolarization, even if it wasn't hidden there, would be very, very difficult to see. You'd actually have to increase the gain, in other words, the picture, to be able to record it. Now, I told you that there was other things that you had to know. So you have to know what an interval is. And remember, I told you an interval was a segment that included at least one P wave. This is called the PR interval. If you have an older textbook, by the way, you will probably see one that says a PQ interval. Clinically, and I made this stupid mistake about 4 years ago, as I said, you will never ever find in a clinical document or a clinical diagram them using PQ interval, because it's just never used. It's always the PR. And I told somebody I'd give them an A in class if they found it. Well, somebody, of course, was immediately on their phone and found one obscure little thing from Japan. He didn't get an A in the class, but I did get an A for the exam. I had to at least stick up someone for opening my stupid mouth. But so I won't get that. But it is called the PR interval. Now, for some reason, there's a lot of anatomy textbooks that call it the PQ interval, and clinically, it really is the PR interval. Okay. This is the amount of time it takes from an impulse that starts in the atria to go down to the ventricles, to go through that bundle of his. And this is an area that you actually measure on an EKG. Now, most of these things are actually measured as the EKG is being done. You don't have to get your calipers out. But, and sometimes you don't even really need the calipers. But if there is, remember I told you that there was a delay from the SA node and the AV node slows it down a little bit? Okay, that's what this represents. So if it's longer than 0.2, you don't have to write 0.2 down, but if it's longer than 0.2, then we have a block. Something that the AV node, for some reason, is just doesn't want to pass the impulse along. So there is a greater delay. Okay? And the blocks can be significantly longer. And it just means that there's a problem happening farther down. Now, the second interval, a little bit more obscure. You're not going to hear about it very much unless you work specifically with cardiac patients. It's called the QT interval. It's from the beginning of the Q and it includes to the end of the T wave. This is the total amount of time that the ventricle is what's kind of referred to as in play. In other words, when it is being both depolarized and repolarized. Now, this is a genetic problem, or can be. It's called a long QT syndrome. So if you happen to read the paper or watch the news and you see somebody who is younger or an athlete that just drops, they're at a game, they're at a practice, something, more than likely it's going to be generally four things. Drugs, one of the things we always think about. Something happened in their head, or this is probably one of the big things. The second thing is the whole chamber thing. So there was an OSU football player who died, and it had to do with the fact that he had a cardiomyopathy where the chambers weren't. Since it's a muscle that responds to training, the wall is going to get bigger, but we also hope that the chamber gets bigger as well. And when the chamber doesn't get bigger, when the wall gets bigger, that's where you end up with those problems. So, because young people aren't supposed to die.
How is it sudden then? Wouldn't that be a really gradual thing?
No. This is I'll show you a video in just a second. It's kind of to drive the point home. But essentially, there's an impulse that occurs. Remember I told you that we had that absolute refractory period that was a certain point so that you don't have the heart clench up. It's also so that you don't have an impulse coming down. And if I have an impulse that hits here, and because it's a long QT syndrome, this actually is a little farther out, which means another impulse can hit here, and it sends the patient into a lethal arrhythmia. In other words, blood's not going round and round anymore. And that is something that happens like that.
Is that the same thing as like what happens with bodybuilders and using HGH?
It can contribute to it, yeah. But not the long QT syndrome. Long QT syndrome is genetic.
Right.
So it's referred to as a channelopathy. So one of the channel, the calcium channel, the potassium channel, what have you, there's a problem, and so it's letting things in that it's not supposed to. It's called a channel. Now the last one is referred to, did you have a question?
I was just wondering if things can go wrong at the PR interval, or is it typically what QT to cause
It
it?
could go wrong anywhere along this
Okay.
process.
Is it more common at the QT? No. Okay.
Nope.
And it's still cardiomyopathy?
No, cardiomyopathy is one of the things. What I was saying, when a patient drops, if it's a young patient, generally you're looking for things. Drugs, head, so they have a bleed in their head, the heart, and the heart can be So the last one is called the ST segment. Remember, a segment is a line between two waves, but we don't include the wave. Okay? So an ST segment, it can do a variety of different things and be an indication of different things. Usually, we look at where it is what's referred to as the isoelectric line. The isoelectric line just means, where's my baseline? This is the isoelectric line because they're all on that same line. So if this line moves up or down, it's indicative of a problem. So if you've ever seen a firefighter's helmet, it's probably one of the best ways to describe ST elevation, an ST segment elevation. So you kind of have the brim, and this is not a perfect drawing, but it goes up, and this is usually where they have the emblem of the station that they're with, and then kind of goes down in the back. I don't want to go down that far. This is my isoelectric line. This is ST elevation. It doesn't come to baseline. This usually means that there's a problem going on with the heart. Okay? So, and again, you don't have to write this part down, but when I have a patient who's having a heart attack, okay, a myocardial infarction, we look at this. Because if this is elevated, then they're having an ST elevated myocardial infarction. It's called a STEMI. And we like to know that because these patients respond to, we talked about these when we talked about clots, fibrinolytics. I can give them a fibrinolytic and break the clot down and hopefully bring this back into normal view. Again, that's not going to be on the exam. I'm just trying to drive the point of what an ST elevation is. I'll get your question in just a second. You can also have ST depression. So if I have a patient that's been complaining of chest pain, but I don't really see anything on X-ray, or on EKG, excuse me, and I'm going to do what's called a treadmill test. So we hook them up to a monitor, and we monitor them, and basically we walk the piss out of them. We just keep increasing the angle and increasing the speed until we see them having some sort of cardiac arrhythmia. And then we see where it's at, and then I can say, oh, well, we might as well go ahead and see about getting that taken care of. So in other words, the problem is significant enough that you might see it, but not all the time. Here I'm basically making the patient have, I'm working them too hard, okay? And that's where you get things like angina, that crushing of the chest.
So these arrhythmias and dysrhythmias, what does that indicate? Either the ventricular or or
It just depends on what it is.
okay, so like the different locations, if you had ST elevation, that would mean something is happening with ventricular regurgitation, or the impulse is not being transmitted, or like what's the?
It's more that you're not getting oxygen to a certain part of the tissue. You're ischemic.
Okay.
Okay, that would be it. So keep in mind that when we do, so those of you who work with patients, put them on monitors, usually you're looking at the patient from one view. Okay? Occasionally we can do it so you can look at him at 3 views. That's one of the things that we're all going to be doing when we do the lab. Now, if I'm going to buy a car off of the internet, and it's going to be basically sight unseen except for a picture, and they have a accident that occurred, or the rear right fender is all banged up, but they're taking a picture from this angle here on the driver's side, I don't see that, do I? Okay? So really what you want is someone to go around and take a 360-degree picture of the heart. So when we do a 12-lead EKG, it's really not 100% 360. We usually do what's called a 15, which is a little bit more rare because it gets the posterior and the right side. We're basically looking at the heart from here, 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 here. You're taking that picture of the car, 12 different views. That's what a 12-lead EKG is. Okay? So what you see here is really just a snapshot of one part of the heart. So that's how you're able to tell if I have ST elevation in lead 2, lead 3, and AVF, then I know that I'm having an inferior infarct. In other words, the bottom part of my heart is what's having the problem. And that would tell me probably more than likely the artery that's being clogged. So when you go to the cath lab, the cardiologist is going to be able to pinpoint it much quicker based off of that particular thing. Now, just to give you an idea, so these are, and I am no way, shape, or form going to put EKGs on an exam. Okay, some people do. This takes a lot of practice. Lots of years to really get good at EKGs, so I don't think that it's necessary to put them on an exam. But just to give you an idea, so whenever you approach an EKG, until you get really good at it, you're always going to approach it the same way. So you ask, are there P waves? Are there QRS complexes? Are there P waves before every QRS complex? Are there QRS complexes after every P wave? So when you look at it, it's like there's a P wave, there's a P wave, there's a P wave, there's a P wave, there's a QRS complex, and there's one of these before, one of these after. In other words, this caused that. Okay? And because it's less than 100, this is referred to as normal sinus rhythm, NSR. You'll see that a lot. Okay? Anytime you hear the term sinus, it means it's coming from the same house. In other words, it's coming from the SA node. Now, when you look at this one, I don't really see any P waves. I see QRS complexes, but I don't see any P waves. Okay? Means this impulse is coming from below the SA node. This is called a junctional rhythm because I don't see any P waves. Now, here, there's a P wave, 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 there's a P wave. It's a QRS. Do I have P waves where there is not a QRS complex? Yeah. There's a P wave right there. There's no QRS complex. So that impulse got blocked. This is an example of a block. So something happened up here in the atria, and it wasn't able to come down here to the ventricle. Okay? This just happens to be a second-degree heart block. There's two types. There's a type 1 and a type 2. This is a 2 to 1, so you wouldn't be able to tell which one it is from that standpoint. Now this, when we were talking about something happening immediately, this is called ventricular fibrillation. So if you were to cut open a patient's chest, if they had this on a monitor, it would look like their heart was filled with a bag of worms. So remember that the heart is supposed to contract like a functional succussion, an all or none phenomenon. Here, a bunch of cells in the heart, they're all firing. Well, if they're not firing together, it's not going to pump blood in the forward direction. This person's dead. Now, I will tell you, either this rhythm or one that looks like this, for those of you who work on a telemetry floor, that's called ventricular fibrillation, or ventricular tachycardia. And your patient's on a monitor, and you're at the telemetry, and you see that, and people get all excited, and they run in the room, and your patient's not there. Where do you suppose they are? Doing what? Brushing their teeth. So anytime that you move, this is the reason why we always treat the patient, not the monitor, so it's not uncommon that this might be artifact. So when you see your patient talking to you and they have that on the monitor, then the monitor's wrong. Because that rhythm right there, you should not be talking to. You're dead. Okay? So you'll see people brushing their teeth, and it mimics this or it mimics that. And you tell them to stop brushing their teeth. So there's going to be one time they're going to do it, and you're like, ah, Mrs. Jones is brushing her teeth. And Mrs. Jones is probably dead on the floor. Now, just to put the video I'm going to show you in context. So when you have this person needs to have electrical therapy immediately. If they do not, they will die. That's all there is to it. Okay? And it's not, pulling wires out from the wall and doing a MacGyver, you're going to hurt yourself more. So this is what we refer to as called a defibrillation. And what defibrillation is that I'm going to put paddles on their chest, or I'm going to put patches on their chest, and I'm going to push a button down. And the minute I do that, the electricity comes out of the machine, goes to the patient, and they get defibrillated. Okay? This we only do with dead people. There's a rare example where we do it with live people, but for the most part, defibrillation is done with dead people. Now, there are patients that have a rhythm, but it's a rhythm that looks more like something caused by this. So they have a pulse, but they're not doing well, and I need to get them out of that rhythm. And in that instance, I need to make sure that I deliver an electrical stimulus to the heart, but I don't want to do it send the patient to that rhythm and kill it. Okay? So what we do is we do a thing called cardioversion. And in a cardioversion, we highlight the QRS or the R wave, and I push the button down to send the electricity to the patient. So the door's open for the electricity to come out, but the machine decides when to send it out. It's timed. It's called a synchronized cardioversion because I'm synchronizing it with this. Okay? And again, these patients are alive. It's still extremely painful. So just to orient you a little bit. So this is an anesthesiologist. We usually medicate the patient appropriately so that they tolerate it. Sometimes we use just pain medication. Sometimes we use anxiolytics like Versed. Sometimes we use both. Here they're going to be using propofol, which is the drug that killed Michael Jackson. So they've got a heart monitor up here. This machine is going to send the electrical impulse to the patient. Okay? What's funny is that everybody, for some reason, thinks that the anesthesiologist has no clue what the hell he's doing, because they're always telling them what to do, and they don't know why. And listen to what the patient says every time they call you. So he's going to get cardioverted 2 more times. So it wasn't successful. See, they're always telling them what to do. I don't know why. So it still didn't work. He's still in the rhythm that they want to get him out of. And again, if we just applied the paddles and shocked him, we might put him in a lethal rhythm. There's your propofol right there. So he says, oh my God, everything's like this. So this one was successful. It actually converted him. So then they would just basically monitor him because of the drugs he was on and make sure he'd get a follow-up with the cardiologist. That's what he's a cardiologist. That's because he doesn't work in the ER. Somebody else needs to take over now. This isn't my thing. I'm out of here. I think this one shows you
We're going to be doing
the rhythm a little bit closer. So see these markings there? Okay, so he's at 187. Okay, you shouldn't be doing that laying in bed. Okay, you really shouldn't be doing that out running. Most of us don't get our heart rates up to 187. See these little marks here? That's that synchronized thing I was telling you about. That's so the machine, when I push the button down, it opens the door and it times it with these little marks so that I deliver the electricity at the right moment so that I don't send the patient into a lethal arrhythmia.
Like that game with the arcade where you press the button. It's all in the right level.
So that's a regular rhythm now. So they cardiovert. Now you see P waves, QRS, P waves, QRS. So it wasn't that rapid rate, which was atrial flutter than what she was in before. Any questions on that? All right, why don't we take a break? Come back, we'll finish up a little bit more of the heart. Don't take a long. Okay. So one other thing I want to say, simply because you'll see this both clinically, it's also written in your textbook. It's another one of these things about ECGs, EKGs, basal ganglia, basal nuclei. The more common term you're going to hear is an arrhythmia. So when somebody's heart is not in one of these normal sinus rhythm, then they're having arrhythmia. Now the reason that people didn't like that, or some people didn't like that, is because again, when you see the term that you recognize as a rhythm, and I put an A in front of it, it means without. It doesn't say without a heartbeat, it just says without rhythm. Well, a normal rhythm is what it's meaning. So you will see people that will use the term a dysrhythmia. Okay? So there are medications that you might be put on that say it's an anti-arrhythmic. So that's one, but you will also see anti-dysrhythmics. But again, arrhythmia is still probably the most common term that you're going to see. They mean the exact same thing. Arrhythmia, dysrhythmia, exactly the same thing. One's just used more commonly than the other. Okay, so we have this going in a little bit more into the contraction, the mechanical component of the heart. We know that the electrical component caused by those pacemaker cells, we can look at it on an EKG. So we have our atrial depolarization, ventricular depolarization, ventricular repolarization. But now we have some of the mechanical things that are going to occur. One of the things that you're able to hear is a thing called the heart sounds. Okay, there's actually 4 of them, but for the most part, we only look at 2. Okay, if you're a little bit more experienced and so forth, a cardiologist will look at more. If you have a pediatric patient, an adolescent patient, they actually have an S3, but there is an S4 as well. So the sounds are essentially caused by the closure of your valves. Okay? So the first one is the closure of the AV valves, the atrioventricular valves. So tricuspid and mitral valves. Okay? And there is a slight difference that one closes quicker than the other one. But again, you have to be extremely astute at being able to pick up those differences. The name that we generally hear, lubbed up, lubbed up, lubbed up, lubbed up, that's the noise that you'll hear when you take your stethoscope and actually put it on the patient's chest. Okay, and I'm going to show you kind of where you put it depending on what you want to hear. So as the valves snap shut, okay, it's going to happen milliseconds before the ventricles contract and shove blood up against it and then off into their appropriate vessels, whether that's going to be the aorta or whether that's going to be the pulmonary trunk that goes in the pulmonary arteries. So a couple different textbooks use a different analogy, but if you think about the chordae tendineae, they're attached to the cusps. So the cusps close when there's a pressure difference, and then you have a tightening, just milliseconds of the papillary that kind of pull it down. Okay? So it prevents this umbrella from flying back in an opposite direction, like if you were in a big giant wind and the umbrella did you no good. All right? That's what's causing the noise. It's both the contraction of the papillary muscles as well as, and kind of making this twang sound, as well as the blood being shoved up against that particular valve. Okay? The second noise is closure of my semilunar valves that occur in the aorta and that occur in the pulmonary artery, pulmonary trunk. So as those open, blood goes out and then it comes back down. Now, when we listen to them, and again, every textbook's just slightly different, but you can kind of get an idea that I've got my aortic valve, my pulmonary valve. We're up in about the second intercostal space on both sides of the sternum, because noise actually travels. So here you can see, here's where the actual valve is. This is the best place to listen for it. Here's where the aortic valve is. Here's the best place to listen for it. Now, when you want to listen to the tricuspid valve, you're going to be, again, around the fifth intercostal space, and you're going to be just, again, slightly underneath the, where you were listening to the aorta. So about midclavicular, a little bit more medial than midclavicular. This one's way, way out. So the mitral valve, you can see mitral valve is here, and I'm going to be listening to it, again, basically the same spot in fifth intercostal space. So again, you're going to be looking at the spaces in between the ribs, intercostal. This would be a space between the fifth and the sixth rib. But but you notice I'm pretty much all the way over to anterior axillary line, to auscultate. So when you're specifically, when somebody who is not just saying I want to listen to their heart, when you have a cardiologist come in and they're trained basically to go over the whole thing, and you'll also see them change positions because when they lie down, it takes the diaphragm off. Sometimes they'll have them lean forward because it brings the heart closer and you can hear different sounds from that standpoint. So it's fairly impressive to see a full cardiology evaluation. But here they're going to be listening to the specific sounds. Because I don't want to hear, anytime fluid moves in a direction it's not supposed to, then blood flow is not laminar. Okay, it's turbulent. So we hear turbulent noise. Turbulent would be your whitewater raft, or your whitewater, that raging, tumbling, as opposed to a little tiny lake that has both fluid coming in and fluid going out. So if I'm listening, I should hear the lub-dub, lub-dub, lub-dub. If I hear noises other than that, it means that blood is moving in a direction it's not supposed to. That's what's called a murmur. Okay? So when you hear that somebody has a murmur, we talked about, remember that PFO, the patent foraminal valley, of things moving through the atria? Okay? You could also have one called a ventricular septal defect, where blood is moving back and forth between the right and left ventricle, because there's a hole in the septal wall. Okay? So from that standpoint, it would be indicative of some sort of disease process. Some people have murmurs that are nothing. Some kids have murmurs that go away when they become adults. Murmurs are extremely difficult to get down. Okay, so as you start to progress into your healthcare system, because I was a therapist before I was a nurse, so I had breath sounds just down, 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 and that's why I said never write anything down that you didn't hear, and sometimes things go away. This is one I could never get down, because most of the population I was working with is the pediatric and neonatal population. So when you're listening to somebody who has a heart rate of 160, it's extremely difficult to hear blah, 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 blah. But you'll hear people are like, oh yeah, they have a murmur. It's like, okay, I'm just going to take your word for it, because I could never hear them. I could never get them down. Much easier to start in the adult population where the rates are much lower, because you have time to start training. So those of you who are going to work in that area, when you have somebody that has a murmur, or when you see a cardiologist go in there, definitely follow them in and figure out so you can start hearing what they sound like. It's a good skill to have. One I never really picked up. Now, when we talk about the physiology, the contraction of the heart itself, there's going to be two terms that we're going to use. Systole and diastole. We're going to come back and use these terms in the vascular system when we talk about blood pressure, for systolic and diastolic blood pressure. But here, we're talking about the ventricles. Okay? So, when we go through the Wicker diagram, I'm going to show you that there is an atrial systole. Systole just means contraction. Okay? But when we just use the terms in general, systole and diastole, we're talking about only the ventricles. So if you don't see a word in front of this, we're talking about the ventricles. This is the contraction phase when the heart's squeezing, blood is being pushed in a forward direction. This is the relaxation phase. So hopefully before we ever even get started, you kind of have an idea that the heart is going to fill with blood during the systole or the diastole. Why? Because it's open. If you think of a sponge, think of your heart being a sponge. Okay, so if I take a sponge and squeeze it in my hand and put it under water, is it going to fill with water? No, because we're squeezing it down. It's when the sponge is relaxed is when it starts to fill up. That's the exact same way with the heart. That's when the heart gets blood back, is during diastole. Now, this text is going to go with what's called the Wicker diagram, which is this. Okay? Very, very busy diagram. There are some of my colleagues that make their students learn it. We're going to go over it. We're going to look at parts of it. And I want you to understand the individual parts, but you're not going to have to reproduce this by any stretch of the imagination. But you do have to understand the three main phases we're going to talk about. Okay? The reason that people like this diagram is because it basically puts everything together. If you notice the very, very top, we have the EKG. So that's the electrical component of the heart. We have our heart sounds, and then we have our pressures and volumes, and then down here we have when our valves are open and closed, and then a picture of that exact thing. Okay? So it lets you know, okay, these kind of work together. So remember I said that if there was no word in front of systole or diastole, then we're talking about the ventricles. Here we have an atrial systole. It's contraction of the atria. So notice, here's my P wave, and this is the thing I was trying to drive home earlier about the electrical and mechanical. So the P wave represents my electrical, correct? So there's that. Notice how the P wave, this is the mechanical. This is my atria contracting. Notice how they're not one on top of the other? This is occurring slightly before that. So it tells you that this, the depolarization, caused that. That's a rapid rise in my atria, the pressure inside the atria. Okay? So what I'm going to do first is I'm going to talk about it from a text standpoint, which is this. So there's three primary phases. And then I'm going to show you what it looks like back on the Wigger diagram, so that you can start putting the things together. Again, I'm not going to have that diagram on an exam, but you do need to tell me what's happening in these phases. So the first one is we have ventricular filling. And again, this is a passive process. What does that mean? There's no energy. Because those valves are open all the time, correct? The atrioventricular valves. So as blood comes back either from the pulmonary veins into the left atrium, there's no floor. So it essentially just falls right down in the ventricles, filling the ventricles up. Blood's coming back through the superior vena cava, inferior vena cava, and that coronary sinus. Comes in. There's no floor because the valves are open. So it just dumps down. That's what I mean by passive. No energy. Now, there is a atrial systole that occurs. Clinically, we often refer to this as the atrial kick. In other words, now that all of the blood is moving through, any excess blood that might be present in the atria, I want to squeeze down. Why? I want to send it to the ventricles because the ventricles are then going to pump that blood to the pulmonary artery or the aorta. So in other words, I'm getting the last bit of blood from the atria so that the ventricles have more to work with. Okay? Now, your book is going to say that it's really not that much. It really is that much. I mean, some books even put it a little bit higher. So if you are in atrial fibrillation, which was the rhythm that that last person was in, their atria, so remember I talked about ventricular fibrillation, where if I was to open their heart up, it would look like worms inside. Well, somebody who's in atrial fibrillation, it's just their atria that are doing it. Okay? Well, if you're just sitting here, yeah, you probably will not miss that 10 to 15% of the blood. But if you get up and walk around, if you get up and do something, and your body needs to have more oxygen, more blood, you're going to miss it. You're going to get lightheaded. You're going to feel fatigued. So the atrial kick is very, very important. Now, this is happening during what phase? When does the heart fill? Systole or diastole? Diastole. So that's my resting phase. So the phase that's going to occur right after diastole, systole. So after I have my atrial kick, I have the largest amount of blood in the ventricles. So it's called my end diastolic volume. In other words, how much is there right here before systole? Now, I will tell you so you can start making appropriate marks in your notes. This is where students get confused. End diastolic volume. What is the volume at the end of diastole? It should be the highest amount because that's when the heart fills. Systole is when the heart empties because I'm pumping the blood to the rest of the body. So in my ventricular filling phase, that's where I have my end diastolic volume. Now, at this particular point, there's a greater amount of pressure in the ventricles than there is in the atrium. So my valves snap shut. And what's going to happen at this particular point is that the ventricle walls start to contract. And they're building up pressure, and they're building up pressure. For those of you who lived here a long time and used to go to duck games, it's probably about, I would say, 7 or 8 years ago where they were in the tunnel. And they would show them in the tunnel, and everybody's getting all jacked up for the game, and all jacked up for the game until they just basically come out of the tunnel. It's kind of what's happening here. The ventricles are starting to contract. The valves are all closed. My AV valves are closed, and my semilunar valves are closed. So you're building up pressure. It's like churning it. Think of a pressure cooker. And you're building up pressure until eventually the pressure inside the ventricles is greater than the semilunar valves. So then blood is now ejected out into the pulmonary artery, into the aorta. Now, right before you have contraction, this is what's referred to as isovolumetric contraction. Big long word, contraction, meaning that we're going to start shortening the muscle length. Isovolumetric, iso means same. Volumetric means volume. In other words, I'm not changing the amount of blood in the ventricles. I'm just building up pressure until eventually we have ventricular ejection. Blood is then going to get shot out of the pulmonary artery and shot out of the aorta into their appropriate circulations. And then again, any blood that didn't go over the arch, that doesn't make its way out to the lungs, comes back and gets caught in your semilunar valves. That prevents the blood from going back down into the ventricles. So since this is one big giant circle, if the blood volume at the end of diastole, right before contraction, is called end diastolic volume, what do you suppose the blood volume right at the end of systole is called? Magic. End systolic volume. The amount of blood that's left after contraction. So obviously the difference is, what did I start off with and what did I finish with? So if I have my end systolic or end diastolic volume, and I subtract my end systolic volume, it gives me a thing called a stroke volume, which is the amount of blood that left each of the ventricles. And by the way, the amount of blood that leaves the right ventricle is the exact same amount of blood that leaves the left ventricle. If it didn't, you would end up with backing up. Because even though these are two separate circulations, they are connected. They're in a series. So if the right ventricle wasn't doing its job, blood is going to back up. Which is going to put more work on the left atrium because it's going to have to pump, or the left ventricle because it's going to have to pump blood against a backed up system. Now, at this particular point, all of my valves are now closed again. My atrioventricular valves are closed, my pulmonary valves, or my semilunar valves are closed. This is referred to as isovolumetric relaxation. So the chambers aren't contracting anymore. Iso means the same. Volumetric means volume. It's the same volume. Now, blood's coming back. This blood is circulating throughout the whole entire body. So it's now coming back to the left atrium and the right atrium. And remember, our valves are closed. What do you suppose opens those valves again?
Pressure.
What kind of pressure? What's pressure coming from?
Coming back to the heart.
The blood coming back to the heart. Eventually, there's more blood that's coming into the atrium, and then the doors open. And now my atrioventricular valves are open, and we start the whole entire process again. So when you look at this diagram, okay, so you can put your pencils down. I just kind of want to walk you through this process. Everything I just said is in this diagram. So we have, let's look at the volume. This is the volume inside the ventricles. Notice how it's going up. And then it stops right there. But then I get an increase. Where does the increase come from? atrial systole. So I get a little bit more blood, and now I have the most blood I can possibly have in my ventricles. My end diastolic volume. Okay? Now, notice here, so these valves were closed already, my semilunar valves. My atrioventricular valves, now they're closed. So both of them are now closed. So this is where we have that isovolumetric contraction. I'm going to start contracting the heart muscles, and notice how the pressure is going up, going up, going up, going up, going up, until eventually it overcomes the semilunar valves. They're now open. And you can see the picture where the semilunar valves are now open and blood's being ejected out. So if blood's being ejected out, the volume should go down. So I'm done with systole, so that's my end-systolic volume. So the difference between end-diastolic and systolic is my stroke volume. The amount of blood that got pushed out of the heart with each beat. That's what stroke volume is. So every time that you're feeling a pulse on a patient, you're feeling their stroke volume. It's being pushed out of the heart. The valves are still both closed. And then if you notice up here, the blood was coming back, and now the pressure goes up inside the atria until the pressure is greater than the ventricles and the valves open. And notice what's happening now. My blood's coming back in. So this part over here is just a beginning part of that right there. So I do think that it bears saying that, again, even though this is not going to be on the exam, the picture, all of this is on the exam. This is just a way for you to take this information and put it in a graphical form so that you can start putting things in their appropriate spot. Because the thing that you should probably have down is the fact, again, when you're looking at this, here's my QRS complex, which is my ventricular depolarization. Ventricular contractions occurring in here. So again, it shows you this causes that, but this is not ventricular contraction. That's ventricular depolarization. Any questions on that? All right, so I'm going to go ahead and stop there. Again, try not to shove too much information at you with each sitting, but basically what that means is you should be taking this time to really make sure that you get this information tucked in your head. Because there's a lot of physiology in the cardiac, and there's a lot of physiology in the vascular system. Okay?